Hey, you guys, let's talk about GERD. I commonly receive questions about this because of the guideline changes for treatment. So let's just talk about it. Let's get to the short and sweet, and then we'll talk about the changes in the guidelines over the past couple of years and how to apply for board purposes. Now, GERD, is gastroesophageal reflux disease. So what's happening is that valve of the stomach is not closing as it should, so the stomach acid is refluxing to your esophageal region, causing irritation to the esophagus, right? And so when the patient presents to you, they may have complaint of heartburn, that burning sensation in their chest. They may have belching. They may be bloated. They may have abdominal discomfort. They may be nauseated. They may have regurgitation. It really varies patient by patient. To diagnose them with GERD, the common test is an EGD, that upper endoscopy, so that you're able to look at this. They're able to be evaluated for the esophageal region. It may not show the active reflux, but it will be able to show if there's any esophagitis, so any inflammation due to that chronic irritation to the esophagus. With a confirmed diagnosis of GERD, we want to move to the treatment options, right? With anything we tell them, lifestyle modifications such as eating 6 small meals versus 3 large meals, not wearing restrictive clothing, because like tight belts and things like that can contribute to that abdominal discomfort. At night, raising the head of the bed, getting the blocks of stands to adequately lifted. Pillows really do not suffice for that. So doing that, even all the way down to the babies, pediatrics, they have the wedges you can put under the mattresses to elevate that head region. And then they can use the over-the-counter medications, PRN. Antacids are very common, like your Tums, your Rolaids, your Mylanta, because they work so quickly. You can also get those H2 antagonists over the counter. They don't work as fast as the antacids, but they cover those symptoms longer. Now, where the treatment, when we actually start to prescribe therapy for those who are having that chronic GERD and official diagnosis of GERD, the conflict has come in where it used to be H2 antagonists as your first line therapy. Now guidelines have switched to making those PPIs, those proton pump inhibitors, as your first line therapy. And here's why. It's because proton pump inhibitors are going to they have superiority because they help with that inflammation. So also we are helping with the symptoms, but we're also healing the problem. And so they have moved that to first line therapy. H2 antagonists are still used as a PRN basis, but don't get yourself so hung up for boards, because they're not going to put you in a situation where it's like, should you pick a H2 antagonist over a PPI over someone who is just diagnosed with it, if that makes any sense. If anything, they'll tell you like the H2 antagonist if you're using this as like a PRN mechanism, but if the provider, the nurse practitioner, is prescribing the first medicine, PPI is your first line therapy. Okay. All right, you guys, bye y'all.